everyone. Welcome to PHO Rounds today. We have a presentation today on wastewater surveillance of COVID-19, potential applications, challenges, and experiences Ontario. My name is Jenny Kim. I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. So before we start, we're right on time, but just before we begin the presentation, I'll mention a few housekeeping items. First, Zoom allows attendees to have the ability to customize your own view, and you can do so in the right-hand corner of your own screen. Please also use the Q&A pod if you have questions during the session. We'll save the questions until the end of the presentation. And we've disabled the chat pod to limit distractions during the presentation. So please do use that Q&A pod instead. If at any point during the session you experience any technical issues, please email capacitybuilding, all one word, at oahpp.ca. That's capacitybuilding@oahpp.ca, and we'll try to address your issue. And finally, I, as the moderator, would like to state that I do not have any potential conflicts of interest to declare. So now moving to our presentation, we're so happy today to have this presentation on wastewater-based epidemiology. It's now my pleasure to introduce the speakers for today's session: Doug Manuel, Bahar Amin Vaziri, Ramsey D'Souza, and Shinthuja Wijayasri. So just to provide a short biography of our speakers, Doug Manuel, MD, MSc, FRCPC, is a senior scientist at the Ottawa Hospital Research Institute and is a distinguished university professor in the Department of Family Medicine and the School of Epidemiology and Public Health, both in addition to holding a Tier 1 clinical research chair position in precision medicine for chronic disease prevention at the University of Ottawa. Dr. Manuel is also a senior medical advisor at Statistics Canada, a clinician scientist at the Bruyère Research Institute, and a senior core scientist at ICES. Next, Bahar Amin Vaziri, MEng, PEng, is the manager of the Wastewater Surveillance Initiative at the Ministry of Environment, Conservation and Parks. Bahar is a graduate of chemical engineering from the University of Toronto and has 18 years of experience as a professional engineer in both the public and private sectors in Ontario. Ramsey D'Souza, MPH, is the manager of the Epidemiology and Evaluation Department at the Windsor-Essex County Health Unit. He has worked in public health since 2003 with leading epidemiological initiatives in both health promotion and health protection. With a background in epidemiology, program planning, and evaluation, Ramsey brings his expertise and enthusiasm in applying an evidence-informed decision-making approach to public health. Ramsey holds a master's degree in public health with a specialty in epidemiology from the Della Lana School of Public Health at the University of Toronto. And last but not least, Shinthuja Wijayasri, MPH, is a field epidemiologist with the Canadian Field Epidemiology Program at the Public Health Agency of Canada, and she's currently placed with Toronto Public Health Communicable Disease Control Directorate. I just wanted to start by introducing, wastewater surveillance is going to be, there's going to be various levels of knowledge with respect to wastewater surveillance in the audience, we predict. And so in addition to our speakers session, I just wanted to point to next slide, please. Just a Public Health Ontario focus on that we developed to provide kind of a primer on wastewater surveillance. So if we go to the next slide, if you search wastewater at the PHO website, you'll be able to come up with this focus on that we published in April 2021. If you'd like to know more, it's something that you can look up. And here's a brief outline of what we discuss, what it is, how COVID-19 is detected in wastewater, how has it been used so far in Ontario and beyond, some considerations when assessing wastewater data on COVID-19 from a public health perspective, as well as application for public health decision making. And even since April, so much has developed with respect to wastewater surveillance. And again, I'm very, very happy and pleased to have our speakers here today to speak to some of the advances and developments even since April, as there's, just it's as with everything COVID, each week and each month brings something new. So without further ado, I'd like to invite Dr. Manuel to begin his presentation.
So hi everyone, I'm going to just give an overview, and the other presenters are going to fill in the details with case examples for a lot of it. Just a few conflicts of interest. I think like no direct funding, but I do some consulting for World Bank and have some research funding in these areas. So if anything, might be slightly biased towards a bit of enthusiasm towards it. And I think you'll see in wastewater field, we have a bit of like there's a wide range of viewpoints, and I think this is one area that one challenging area where we need to get sort of move towards more consensus building. So next slide. So just talk about what wastewater surveillance is. Very quick 101. The gaps. This is maybe why I'm a little bit excited or enthusiastic or interested in wastewater. Overview of uses, future uses, and then the challenges. So it's a lot about use, opportunities and challenges, managing the opportunities and challenges. Next slide. So this is kind of the overview. Most people, when they have COVID, they excrete COVID, through their respiratory system and also through their feces. And one of the catch terms is everyone poos, like in the wastewater surveillance. So, and there's a few gaps, long-term care residents that are in diapers, or people on municipal systems that are on septic systems or others. But for the most part, this is one of the strengths. We think that it follows a sort of gamma curve. It goes up quickly while you're asymptomatic. So that's a key point. And it travels through the sewer system, and that's called transit time. And there might be lift stations and holding bins and lots of different paths in the journey to the treatment plant. You can sample along the treatment plant, along the sewer system, before or after buildings, in neighborhoods. But a lot of the testing is done at municipal plants at the intake, where the sewage goes into the municipal plants. It's taking grab samples, continuous samples, all samplers, lots of different approaches for this, rapidly evolving in all the different settings. You take the sample, you're taking measurements of the wastewater system as well, in terms of temperature, flow rates, rainfall, and then you're taking that to the lab. Most of the testing in Ontario is done in academic labs, which is similar worldwide. And you're doing PCR, like we do PCR in the clinical setting. There's a lot of other steps for filtration and concentration, which adds some variability, but the assays, PCR. There's now VOC testing, both alleles and what we call metagenomics, or looking at all the mutations and sequencing in the collective, because you're going to have in there lots of different RNA, not only from COVID, but lots of different organisms. So you're isolating the COVID and then looking at the collection of it. And then on a lot of these slides, we lack that use. So I put that in here. So that's just the beginning part, of course. The information is then shared with different partners. Key partners in wastewater is the local public health epidemiologists, medical officers of health, and the environmental staff. But it can be used with lots of different partners. Next slide. And this is just a reminder. One of the things I'm advocate of this open data and sharing this, and it's been a challenge. I think it's coming along, but just a reminder that a lot of this data isn't shared publicly. But if you're sharing just between the wastewater treatment wastewater labs and public health, you're missing opportunities. And so, as we've seen for COVID, I think in general, the pandemic is this wide use of data and how it's really helped develop policies. So next slide. This is maybe the thinly veiled shout out for our program in Ottawa. And this is the Google Analytics for 613 COVID, just the wastewater page. So over 470,000 people have viewed that, different sessions. We have addicted newscast reporters and others that are looking at it every day. And if we don't post it right away, we get lots of calls, what's going on, and lots of complaints. Plus the data, about 500 people are accessing the GitHub repo where the data is, people around the world and throughout Canada as well. Most of the use is in Ottawa, but this is just our website. It's posted every day on CBC website and others as well. And so it's a big conversation point in Ottawa. All the CEOs talk about it, of hospitals, business leaders, mayor and a premier battle back and forth about Ottawa's wastewater. So I think that public engagement has been key to the success of the Ottawa program. Next slide. So what are the drivers of the pandemic and how do those align with wastewater? So this is a challenging pandemic. I don't have to remind you, we kind of forget, like we're in it and we kind of forget. So you have asymptomatic to symptomatic, and those asymptomatics are really challenging in terms of driving the pandemic and the burden driving transmission. Diagnostics. So currently we're relying on testing individuals, and we're starting to have challenges getting individuals in. And there's barriers to testing. It can be costly for a lot of countries. It's costly for us. The inequalities, COVID and inequalities are synonymous. The burdens are so inequitable. And so how to measure it equitably, reaching our vulnerable populations, and helping that inform our policy. And then the spread, it's just difficult to control because of that asymptomatic. Next slide. So it's interesting when you map this over, actually wastewater fills a lot of these gaps. So it captures all stages of the disease, like I mentioned. It is one test. There's extra cost for collection, but there's fewer tests. With one test, you can test a larger population. So it's potentially more sustainable. It captures the population. Like there are two perspectives of population health, population-wide or focus on vulnerable inequities. So you can do both. You can do municipal testing, capture everyone, but there's a lot of testing, as you're going to see, in special populations. Those could be school settings, it could be nursing homes, long-term care homes, prisons, and others. And then there are these use cases. There's probably hundreds of use cases where there's suggestion or finding COVID in early at that where there's asymptomatics or early detection. And so it's been one area. And you can talk with public health folks where they've had first attacks, and they basically swear by it, that it's helped them interrupt transmission. And we'll see some use cases for those. Next slide. Oh, actually, I'm going to ask a non-rhetorical question. And that's it. Can you think of other surveillance systems that meet those challenges of the drivers, or other surveillance systems that we have for other diseases that can capture asymptomatics and population-wide surveillance? It's non-rhetorical. Like I think, and you put it in the chat, because I'm curious. I think environmental testing is an interesting surveillance approach, and we don't often in public health emphasize it during our training. It can be a little bit finicky because all this transit and collection, but they offer they have a role, they have a potential role, and so I'm interested to see what you guys think about those drivers and how surveillance systems rack up against that. This is just filling in about a few of those, how it fills the gaps. Just a reminder that we have this asymptomatic and we have syndromic or clinical testing that's largely further down, although you can do contact tracing to get asymptomatics and pre-symptomatics. And then hospitalization, death are measuring further down. Next slide. I've revised this one since, but this is the idea of this this just population based, and as we're starting to see now, we have potentially a smaller group that we're detecting with high positivity rates and lower testing rates. So one of the potential advantages is this broad base of capturing everyone. Next slide. For uses, you're going to hear about these throughout the next hour, but early detection I've covered, often in small populations, but it could be larger. Population-wide surveillance, and this would be complementary to others. So you're going through these periods where there's a little bit foggy about who's being tested, and you have another lens looking at that, to be able to triangulate what your clinical testing is doing. Specific population surveillance, probably the biggest one has been university campuses, but there's many other examples. And then emerging one is variants of interest and concern and mutations. Potential uses, I think this is really covered off in the other ones, but I think one of the reasons why I got into this last year was where we are now, where we're going to be folding up our clinical testing, and can we provide guidance and confidence to our municipalities and our population that we're low COVID or COVID free. So potential uses, other pathogens, other pathogens, there's quite a few pathogens in our wastewater, but also it's sort of this growing interest in metagenomics, and wastewater is a window into the health of our community with pollutants, drugs, and other things in our wastewater. As well, there's a rapidly growing interest in other environmental testing for SARS-CoV-2. So air and surface, servers in restaurants that will wear a badge that changes color if they're exposed to COVID in the restaurant. And a lot of this is being spurred on by wastewater, or raising our interest in our understanding the potential of that. So that's next slide. This is a repeat, but the other considerations, just equity, resource implications, and people talk about everything I'm showing is pretty much consensus around the world when we have meetings about the uses, and one people talk about is measuring the progress towards vaccination or compliance to public health measures. So just seeing the cases go down. Next slide. Challenges are notable. Three ones that come up consistently are that analytical measurement that I talked about, and there's a lot of effort on improving the assay and quality assurance, and this is improving and still improving over time, and reporting and interpretation. So interpretation needs to involve different parties. It needs to involve your wastewater lab, public health epidemiologist, your municipality. And you're getting together and you're looking at results and you're discussing them together. And so really important to have a collaborative. It's been one of the most fun multidisciplinary areas that I've worked in, period. It's been really, really enjoyable. And when it works well, it works really great. I learn a lot, and you really feel like you're working together, everyone contributing something that other people don't have. And then sustained programs. Worldwide, we have, there's over 2,000 sites worldwide, 2,200 sites, but I think what we have in Ontario, we're seeing in other places as well, where we have initially pilot projects that began last year, largely in university labs. And then we're fortunate here that that those pilot projects congeal into the program that Bahar's on that side of me, that the MECP has been driving and leading. And so you have this organization of pilot projects into programs and initiatives. But a lot of people have struggled through that. And then the question of sustainability. Currently, it's used worldwide, but at last count, there's no use in the lowest income countries. And despite everyone sort of feeling there's a potential role there. So the interest in developing programs worldwide, and our role here in a developed country to advance the science that could be used in disadvantaged populations worldwide, I think is a consideration. So the challenge is in the measurement is these variations at many different points, variations in the excretion between people, the wastewater system. So each wastewater system is really unique. So it's difficult to often compare results from one wastewater system or one municipality with another. So so there's a lot of variation there, and then how you collect it and the factors that contribute to it. There's quite a lot of variation there. So you do see the signal kind of go up and down quite a bit from day to day, and interpretation is a bit more challenging. Thank you.
Thank you very much, Doug. So you covered most of the basics, which is fantastic. And I don't need to hopefully speak too much to the science, which is not my forte. Next slide, please. As Doug mentioned, wastewater surveillance, which is a kind of wastewater-based epidemiology, is underway in several jurisdictions across the world. It looks for gene fragments that are shed by people that are infected, whether they're symptomatic or asymptomatic, and it covers the whole population that contributes to that particular sewer shed. It helps us to quickly identify and respond to COVID-19 surges. And it specifically, it's great for use in areas where we have congregate settings and people get infected real rapidly, and outbreaks are common. And it can also monitor the variants and look at the proportion of variants in populations. The Ministry of Environment, Conservation and Parks, in collaboration with 13 of our academic and research institutions in Ontario, numerous municipalities, and our public health units, has put together this initiative that covers more than 80% of the population in Ontario in terms of surveillance. More than $12 million has been invested by the government to date. And we have been developing this network to look into confirmation of detections in wastewater in addition to clinical sampling, look at higher risk populations within the sewer sheds, and identify transmission trends. And hopefully this program is going to inform decisions on future surveillance expansion and other uses in this province as well. Next slide. The program objective is to establish a coordinated Ontario initiative, develop a wastewater surveillance tool that provides our public health units with additional pieces of information to be able to make decisions and look at the effectiveness of the measures that they implement. We have built a wastewater sampling strategy and network that currently covers over 80% of the population. And we are engaging our partners and experts to look into how we can increase the reliability of the results that are gained using this type of surveillance. We collaborate with other program areas, ministries, governments, academic institutions, and even federal government has been working with us seamlessly. And we have been very successful in establishing a level of collaboration that has not been seen before in other programs. And at the end of the day, another objective is to make sure we can use this program to evaluate the feasibility of expansion of this type of surveillance in this province. Next slide, please. As Dr. Manuel mentioned, the way it works is that neighborhoods contribute to our sewer lines. Sewer lines go to wastewater treatment plants where samples are taken. The RNA fragments of the virus shed into sewage are extracted, and using a method called RT-qPCR, which is a quantitative method to count the RNA fragments, we can look at the infection trends, and we can see in wastewater if the infection trends are going up as more people contribute to the RNA fragments. segments in wastewater. It has been seen that in many instances, the surge in wastewater has been 2 to 3 days ahead of surge in clinical cases or hospitalizations. Next slide, please. Another shout out to our partners in Ottawa, which started their public site before anybody else did. They have been reporting their data and putting the wastewater results on the graph along with the clinical cases. As you can see, not only the trend is very similar and the information is corroborated by wastewater surveillance, but also in some cases, surges are seen in wastewater before they are seen in clinical cases. As people get infected and start contributing virus particles in sewage, it might take them quite a few days before they feel sick, they go get a test, and the test results come back positive. So as Dr. Manuel mentioned, this has become quite an effective tool for staying ahead of surges. Next slide, please. In Ontario right now, we have reached almost 160 monitoring locations. We have about 88 wastewater treatment plants that cover a large population in Ontario. And we did consider not just population, but also actionability of the type of location that we were choosing. We definitely wanted to have northern and sentinel locations monitored, and we built on the previous partnerships that were established between these academic partners and their municipalities. We are also monitoring locations that are upstream from wastewater treatment plants. Some of them are facilities, but which include long-term cares, retirement residences, homeless shelters, prisons, and university campuses, but also communities such as high-risk neighborhoods, especially in the GTA area, and several First Nation communities that have joined our network and are being monitored. Overall, we are looking at over 100 monitoring sites that help us look at infection trends in communities across the province, and 55 locations that are looking at specific facilities such as prisons or shelters and long-term care homes, etc. Next slide, please. These are some of our key achievements as of last week, and we are making great progress on a daily basis. So some of these numbers have become outdated already. We have established a data and visualization hub where the results feed into the system, and they are visualized and graphed for the public health units and municipalities that are partners of the initiative. And I'm happy to announce that as of this afternoon, we will have provided access to 16 sorry, my apologies, 21 public health units in Ontario, so that they can log in and take a look at the results of wastewater surveillance in their jurisdictions. So we have only a few more to go before all the public health units in Ontario have access and can benefit from the data on the visualization hub. Next slide, please. This is how it looks like when the partners that have access to the visualization hub log in. They see a map of Ontario with all the public health units and public health regions. Each public health unit only has access to the data in their own area, same as the municipalities and their own data. We are working actively with not only public health units, but also Public Health Ontario and Public Health Agency of Canada to sift through the data and look at the interpretation of these data sets and use them for analysis and decision-making purposes. We have established a working group that meets on Fridays, looks at challenges, looks at data interpretation, and hopefully will establish some guidelines in terms of how this data should be actioned in various capacities across the province. Next slide, please. This is a snapshot of our visualization hub for Ashbridges Bay wastewater treatment plant in Toronto. It's actually a little bit outdated. If you log in today, you'll see the data is up to date as of today. But what these graphs provide are various types of analysis from the results that come from our academic partners. There are several gene markers that are tracked in wastewater. There are various ways that they're normalized into the fluctuation in flow and solids in the wastewater. And we have overall 12 kinds of graphs that look at how the wastewater results look like on a daily basis. And at the bottom, you can see that we receive the case data from Ministry of Health, and we do the same sort of analysis with them in terms of looking at daily increases and active cases. And this provides a really good comparison of which way the trends are heading in wastewater and in clinical cases. Next slide, please. So as I mentioned, we are engaging our local public health units to work with us in using and actioning this sort of data. Right now, we have several municipalities that are participating in the program. I think we have actually increased the number from 54. It's more than that now. And over 26 public health units are receiving data with respect to the sampling locations. And as of this afternoon, 21 of these public health units can actually log into the system and see the most up-to-date results on their dashboard. We hold regular meetings, and we like to discuss challenges and interpretation of the data. And some of the amazing efforts that have come out of many of our municipalities and public health units include the establishment of public facing sites that make these results public. Ottawa was the first municipality and public health unit to do so. They were followed by London, Ontario, Kingston area, York Region, Peel, and Waterloo now. Where they can share the data with the public on a daily basis. Next slide, please. So we established this program back in November. We moved very quickly to establish partnerships. It has been a whirlwind, and it has been very busy and very fast paced in trying to get where we are. But we still have a long way to go, and there is lots of room for enhancements in our program. We ran an inter-laboratory study to look at comparisons of results from all these different academic institutions that contribute the data to the program. We have implemented the recommendations that came out of this inter-laboratory study, and a guidance document will soon be published that will assist labs in enhancing their QA/QC methods. We are expanding the program rapidly, and we're making sure that we have a good coverage of populations across the province, as well as our First Nation communities. The data and visualization hub is expanding fast, and we are hoping that soon we can also implement the variants of concern type of data into this hub, as well as we move on to expand the program to include these additional analyses. We have established terms of use in our data hub, which governs the main data sharing terms with our partners. But when it comes to First Nation communities, we are in negotiations with them and in talks with them to establish very separate and independent data sharing agreements with them that are on their terms. We are very happy that most of our public health units are actively engaged using this data, and we're hoping that we can provide more guidance in collaboration with them regarding the interpretation and actioning the data going forward. And of course, we are looking at how this program can look in the future, how the structure of it will change as we go forward, and we can potentially consider this type of surveillance for future health risks for our population. Thank you so much. And I would like to ask our next speaker, Ramsey D'Souza, to start his presentation.
Thank you, Bahar, and Doug as well. Both of them have gone into a lot of detail into how the methods and science works behind wastewater surveillance, so I won't look to repeat any of what was previously mentioned, but I will look to talk more about a local example about how we piloted a project with our partners at the university to avert a potential outbreak. Just a note, I have no conflicts of interest to declare. Next slide, please. So just a bit of a background for Windsor, Essex. So we are located in the southwest region of Ontario. We border we border Detroit, Michigan, and it's also the busiest land border in all of Canada. Our region consists of 9 municipalities, 4 of which includes Windsor, Lakeshore, Leamington, and Amherstburg. Those municipalities are participating in our local regional wastewater surveillance program. Our population is about 430,000, give or take, and as a bit of a side note, we have about over 20,000 post-secondary students enrolled in our colleges yearly. Next slide, please. So on top of doing routine wastewater surveillance across our region, we were also piloting a project with our partners at the University of Windsor, led by Dr. Michael McKay, on sampling wastewater surveillance on an on-campus facility residence. For those of you who are not aware as well, so we have two locations here. We have a college here as well as a university as well. So for this specific example, we had about 186 individuals on campus residence. We started sampling in February 2021. Initially, we were doing grab samples 3 times a week from February 8th to March 22nd. So this is where we would just go in and collect one sample, one snapshot in time. But from March 23rd to present, we were doing passive sampling using the Moore swab approach. For those who are not aware, a Moore swab is a tool where a gauze pad is tied with a string and is suspended in flowing water or wastewater. The pad absorbs the water alongside fecal matter and other pathogens. It differs from a single volume grab sample which only provides a snapshot in time. Next slide, please. So on March 26th, the samples that were collected had identified SARS-CoV-2. The results were available and analyzed on March 22nd in the morning, and by the afternoon, the health unit was informed. By that time, through our conversations, we were able to provide on-site testing for students who were living on residence. From that, we were able to identify 2 cases, an index case and a secondary case from our contact tracing. Next slide, please. So note that this slide has not normalized for flow. The gray bars indicate our clinical cases. The red line indicates our aggregate wastewater data from across all of our wastewater treatment plants in Windsor, Essex. The blue line and the dots are from our on-campus resident sampling. So you'll see that that COVID was identified in the wastewater, looking at the blue line and the blue dots in late March, which are tied to the 2 cases that we had tested and were able to isolate. The blue dots, the subsequent blue dots that were found in April actually threw us off a little bit. We had thought that there was a new infection on site. However, after further investigation, we had identified that the 2 individuals were actually, they were done their isolation and brought back on res, and they were still going through their post-viral shedding, which will obviously be, it'll be easy to identify that in the wastewater. It goes to show how sensitive the test can be, and the ability to detect even at a granular level. Next slide, please. So what this allowed us to do was to identify that we can do targeted wastewater sampling in high-risk settings. It also further allowed for additional collaboration with our academic partners at the university, but also potentially in other settings as well. And it shows that we can possibly scale this up to college and our university once things open up, especially in the high traffic areas where labs are being done or in-person classes are a must. And also not just outside of the school setting, but it can also be replicated in other areas such as long-term care homes, retirement homes, and our elementary and secondary schools. So that's it for me. I'll pass it over now to Shintuja from TPH.
Okay, thank you, Ramsey, and good afternoon, everyone. I'm Shintuja, and I'll be presenting on Toronto Public Health's most recent work implementing wastewater surveillance for COVID-19. Next slide, please. Okay, so I have no conflicts of interest to declare. Next slide, please. So like Doug mentioned at the beginning, we know that traditional clinical surveillance has many limitations, one of them being its dependence on testing strategy. And those of you working in public health in Ontario will certainly know this was the case in Toronto and in Ontario during the pandemic. Testing in Toronto and Ontario has changed over time as symptoms associated with COVID, lab testing capacity, and priority populations all evolved over the course of the outbreak. And because of this, as mentioned before, traditional surveillance is also going to underestimate the total number of infections. So we're not only missing the full burden of disease, but the data is also going to be skewed towards more severe cases like hospitalizations and deaths, which themselves are lagging indicators and will take time for people to seek medical attention and be reported to public health. Next slide, please. So knowing all this, we as a local public health unit responding to the pandemic needed something that was complementary to our surveillance and was able to fill those gaps. And specifically, we were looking for something that was independent of clinical testing, provide situational awareness to public health, and can monitor COVID trends in a community. And if we were lucky, we'd get something that was an early warning system for changing trends. And that's where wastewater surveillance comes in. And like Doug and Bahar mentioned, we were interested in this because of its potential to capture an entire population with COVID, whether or not they had symptoms, whether or not they've taken a test, in a much cheaper and much earlier way than clinical surveillance. So we felt that it was a tool that was definitely worth exploring. Next slide, please. So what did we do in Toronto? So in this presentation, I'll describe the pilot implementation of COVID wastewater surveillance in Toronto during wave 3 of the pandemic. We'll talk about the value add of wastewater viral signals as the COVID pandemic evolved in the context of a big city like Toronto. And we'll discuss the implications and some next steps for Toronto Public Health. Next slide, please. Okay, so in Toronto, wastewater sampling occurs at 3 different types of sampling locations. We have 4 wastewater treatment plants, 6 upstream community sites, and 5 facilities. I'll start with the treatment plants, which cover around 97% of Toronto's population. Next slide, please. Okay, so like I said, Toronto has 4 wastewater treatment plants covering very large catchment areas with populations ranging from 250,000 to 1.5 million and covering very large geographic areas with very diverse populations. Right now, our university partners, Ryerson and the University of Toronto, are sampling at these sites 3 to 5 times per week. Next slide, please. Okay, so obviously, wastewater surveillance doesn't replace traditional COVID testing, but also can't be a standalone tool. So we have to interpret COVID wastewater signals alongside relevant clinical indicators. And so at TPH, we've been working through how to integrate all of those indicators that we've been experimenting with, such as new cases, active cases, and percent positivity. In this instance, we're presenting the wastewater signal against cases by the date that they were reported to Toronto Public Health, mainly to examine the correlation, but also to assess whether or not the wastewater signal can be an early indicator of cases that haven't yet been reported to TPH. And in terms of the data that we've received from the treatment sites, you'll notice on the graphs here that I presented, they're all on different scales. and we can't really compare between the sites or roll them up to the city level. And that's intentional. And that's because there's quite a lot of variation in the day-to-day sampling due to environmental factors and lab partners continuing to refine their methods, as Doug and Bahar have alluded to. So the analysis is focused on general trends, upward and downward trends, rather than the magnitude or the strength of the signal. You'll also notice that we've added lowest smoothing on the trends to allow for a smoother, more interpretable trend. And the variability in the data that we see week to week calls for that, because it makes it difficult for us to interpret the data as it comes in week to week. So essentially what we learned from the implementation during wave 3 is that the wastewater signal generally confirms what we're seeing in the clinical data, but we're not really seeing much in terms of an early warning, with the exception of Highland Creek, where the signal precedes the increase in cases reported to TPH. We also know that testing rates have declined drastically recently, with testing rates in May 2021 similar to rates we saw a year ago in May 2020. So the wastewater signal is really validating or confirming that the decline we're seeing in clinical cases wasn't impacted by lower testing. So that's the treatment plan. Next slide, please. Okay, the second type of sampling location I mentioned is the upstream community sites, which cover 6 hotspot areas in Toronto's West End. Next slide, please. Okay, right now, Ryerson is sampling twice a week at these sites, which cover populations ranging from 4,000 to 130,000. Next slide, please. Okay, so the upstream site data isn't quite ready for prime time. We only started implementing some of these sites halfway into wave 3, but I presented 2 examples here. And like I said, Ryerson only samples twice a week at these sites, which adds to the variability we're seeing in the data. I presented a 7-day midpoint average on this slide, and you can see the variability I was referring to earlier that we also see in the treatment plant level data. So again, there is some work that needs to be done about the variability, particularly in terms of getting a smoother, more interpretable trend, and getting more frequent sampling and timely reporting back to TPH is part of that work. But despite the variation, we are seeing some potential for the upstream site data to be an early indicator of cases that will eventually be reported to TPH. Next slide, please. Okay, so the final type of sampling locations are the 5 facilities, which include long-term care facilities, hospitals, and homeless shelters. And Ryerson is sampling at these sites twice a week. Next slide, please. Okay, so similar to Ramsey's example, we did have scenarios here in Toronto in university dorms, which showed the same benefits he's already mentioned. So essentially having a signal, capturing a case that wouldn't have otherwise been caught, allowing for Toronto Public Health to go in and provide recommendations like enhanced testing or modified controls, allowing for full case management and contact tracing to take place, and therefore limiting the need to isolate an entire floor or building, and then also essentially tamping down on a potential outbreak. But we wanted to present an alternative example that really highlights how nuanced wastewater surveillance can be in different scenarios, and why public health has to assess signals pretty much on a case-by-case basis. So in this example, we were notified of 2 consecutive positive signals in late May at what we'll call Facility A, which covers 2 long-term care wings and 1 hospital wing in a healthcare institution. We investigated further, and we knew that the facility had recently had several B117 outbreaks. And considering that this is a high-risk setting with the concerns around VOCs, we informed the program area and the facility after the 2 signals. And after some back and forth and some investigation, we discovered that the facility had recently started receiving active COVID cases from acute care into these wings where sampling was being conducted. So the signal might have been due to convalescent shedding. We did have heightened vigilance at the facility in that the facility was keeping an eye out for potential cases and symptomatic individuals, but no enhanced testing was implemented because we knew about the recovering cases and the recent outbreaks. So the sampling was also moved away from the recovery wings. So it's not a concrete success story in terms of case finding, but it is an example for the potential for a more direct, tangible public health action that a local public health unit can take, and also why wastewater signals require the local and clinical context before public health action can be taken. Next slide, please. Okay, and TPH has also started receiving VOC sequencing data recently from FAC, and generally they correspond to what we see in the clinical data, roughly. Clinically, alpha became the dominant strain in Ontario in mid-March, and since early April, clinical cases that were negative for 2 mutations, N501Y and E484K, were predominantly Delta. And these clinical trends were similar to the trends we're seeing in the wastewater sequencing results in terms of upward trends. But more work is needed here, including timely reporting to local public health to see how well the clinical sequencing data correlates with the wastewater sequencing data and determining how it can be used to monitor circulating VOCs going forward, especially as clinical testing continues to wane. Next slide, please. Okay, so what have we learned so far in this short pilot period? So essentially, wastewater surveillance can be a useful tool, but the most useful and actionable data really comes from our upstream community and facility sites. The data from the larger catchment areas are great to corroborate the clinical data, but tangible public health action is really limited when we're dealing with such large population areas. And so action is mostly focused on public health messaging and promoting individual responsibility. So you've probably seen a lot of this with social media campaigns that Ottawa Public Health and other public health agencies have been doing, encouraging people to follow public health measures, seek testing, get vaccinated, that sort of thing. As we get into the more targeted areas, that's where local public health units can have more direct action, whether it's moving resources like pop-up testing and vaccines to specific neighborhoods, or more specifically, targeted cluster and outbreak management and investigation. Next slide, please. Okay, so in terms of limitations that hinder our ability to use wastewater surveillance to its full potential, one of the biggest problems here in Toronto is our very old, very complex, very large sewer systems, which adds to the variability we're seeing in the data, particularly as we sample in the large treatment plants. By the time the RNA gets to the sampling locations, like Doug mentioned at the treatment sites, the RNA in the wastewater has gone through a lot. We're dealing with everything that's also flowing into these sewer systems that we need to try to normalize for. We're talking about rainfall, stormwater, temperature, travel time, and in Toronto, the size and diversity of the catchment areas. So it's another reason why the smaller sites are more promising than the massive catchment areas for wastewater surveillance. We also have difficulty interpreting short-term trends because of the variability, which as a local public health unit really limits our ability to have timely public health action if there are signals we can't interpret, or if we need to wait a few weeks for enough data points that allow for an interpretable trend to appear. And even more of a head scratcher is when there's something contradictory between the wastewater and the clinical data. So for example, I mentioned the issue with active and recovering cases in the facility example earlier, which might cause a contradictory interpretation. I also mentioned earlier that at this point, we're only looking at general trends rather than the magnitude or the strength of the signal, which makes it difficult to know what the signal means. So at this point, we're generally just looking at upward and downward trends at the treatment plants and the larger neighborhoods, and sort of an on-off switch at the facilities and some of the smaller neighborhoods. So it's very difficult for us to gauge how to resource our public health actions without knowing if we're dealing with one case or thousands, particularly at the larger treatment plant catchment areas or the larger neighborhoods. And another thing that's really improving but still needs a little bit of work is the lag time in processing the samples and reporting to public health. So that's really improved quite a bit as we've built the system and refined our methods, but definitely needs to improve, particularly for the sequencing data, at which point it still takes a few weeks to get back to TPH. Next slide, please. Okay, so in conclusion, our implementation during wave 3 allowed us to essentially validate that the wastewater data correlates well with the clinical data. So it can be a useful tool when testing wanes. We also learned that wastewater surveillance at the larger treatment plant levels are largely confirmatory and not really an early indicator. And it's difficult for public health to directly action. So the potential is mostly at the smaller sites where it could be an early indicator that public health units can actually action, particularly when clinical testing wanes. And that's where Toronto Public Health will be focusing our efforts going forward. Again, all of these benefits are quite theoretical at this point, and we will have to wait for the pandemic to wane and for testing and prevalence to be low for wastewater to really prove itself as a useful tool. In terms of public health action, one of the biggest implications, for us is to figure out how to plan in terms of triggers for action, particularly in terms of upstream community sites and facilities, especially to determine which signals are artificial versus which signals should be actioned, and how our program areas can respond with the resources and capacity that they have. So responding to a signal in a transient shelter population, for example, is different from responding to a dormitory or a long-term care home with a more fixed population, which is different from responding to a signal in a hotspot neighborhood. And in the example I presented, we leapt into action after 2 consecutive signals, but maybe going forward, as we see lower community transmission, it might be key to action after 1 signal. So again, many different scenarios that we need to work through. In the meantime, we do need to focus on improving the sampling frequency and the timeliness of reporting to TPH, particularly from the upstream community sites and facilities, to inform public health action in a timely way. And going forward, we'll also need to evaluate the utility of wastewater surveillance at the various sites as reopenings begin, as vaccination coverage increases, and as the population becomes more mobile, in order to identify a resurgence or measure the success of public health interventions. And like I mentioned, some of this work has already begun, but with more timely data, wastewater surveillance hopefully can be used to detect or to monitor trends for existing and emerging variants of concern. Next slide, please. And with that, I'd like to acknowledge everyone at UPH, Ryerson, U of T, and FAC who've been working really hard to get this going. I've really simplified this work into a 15-minute presentation, but it's been very complex and very difficult and very experimental. We're very much building this plane while flying it, so it wouldn't have worked without their teamwork and collaboration. So thank you. Next slide, please. Okay, and that's it, and I'll pass it back to Jinhee.
The speakers have been really busy answering all kinds of questions in the Q&A pod, and actually all we have right now is regarding Doug's non-rhetorical question, a comment that Legionella actually has some similarities to wastewater surveillance of COVID, in the sense that quantitative results are not a direct measure of disease. The quantitative results of wastewater is not a direct measure of actual disease or cases, and that non-detects or detects can be informative in establishing some spatial contrast. So I think that also relates to some final comments I had earlier, in that sort of reflecting on the remarks of our speakers today, that obviously wastewater is a very much a developing area, but it is an environmental monitoring tool, and that context, I think, that was presented by Ramsey and Shinthuja in some of their presentations. The part that we caught of Shinthuja's is really important for interpreting with respect to what it means for health. Lots of really exciting work happening now in within Ontario as well as internationally that we can continue to monitor. There's actually an additional couple of questions also in the Q&A pod, so I can go to one of them. Do any of you have ideas on how to move the data as quick as possible from sampling to testing to data analysis and findings presented to decision makers? I think this is one of the key challenges, putting all of the wastewater surveillance data together in a way that decision makers can interpret. But any of our speakers have any comments?
So there are several challenges in making this data available as fast as possible. One of them is that samples need to get delivered to that particular lab that is doing the analysis. We have done our best to pair up municipalities and sampling locations with their local academic institution so that the shipping time is minimal. However, that's not the case all the time. So you may have to allow for a couple of days of shipping. And then there has to be, once the analysis is done and the data is extracted, it's important to run a lot of QA/QC on the data to validate it before it is uploaded for consumption by the decision makers. So again, there is a few days in between that it takes for the data to be ready, and it can't be really done in real time.
Thanks, Bahar.
Maybe I'll just add, I was just typing the note, but National I always get it wrong, microbiology lab has a sort of challenge grant where they're where people can apply to build a sort of handheld sort of real-time detector that can be used by non-lab techs. I think that's just an indication of, again, the speed that's being developed. And you do have you do have card assays and printed I forget what it is, like printed primers that will light up if it's exposed to air or water or surface SARS-CoV-2. So I think that there's these challenges for sure in that reporting time. I think we're going to see rapidly, like even over the next year. It's been just so fast. I think that innovation is going to continue very quickly.
Thank you. Another question in the pod. Do we know how long to expect ongoing shedding from an already known case? This part of the data seems like it could be challenging to interpret.
I think 40 days is the sort of number that's batted around. So it can be found in stools for quite a long time. You have some sites or some people in the field that feel that you have, if you see something start up, the specificity is very good, and someone is in your wastewater system that that is excreting SARS-CoV-2. Maybe they're in isolation already, they're not going to transmit. Maybe they're a traveler, but there's something there. And then people talk about a longer tail. You can see some of that in some of the figures. So you can have SARS-CoV-2 sort of settling in the solids as well. And that sometimes there's some, I don't think we have it really well specified yet, but this idea that the shedding can last for a while, and also sometimes the transit time in the sewage system can last for a while. And you hear about people as well, if you have a big rainfall. And in Ottawa, we had a really interesting situation in March where there was a lot of snow melt. And we have these massive underground reservoirs, and that affected the signal quite a bit. So you can't have dilutions or collection of SARS in stools in the wastewater system that can take a little while to come out. So you see sometimes these tails. As cases go down, the wastewater goes down more slowly.
Thanks for that context, Doug. Lots of questions coming through. One from TPH, I believe. Is there any evidence as of yet that early detection helps to minimize spread in communities or settings?
I can take that one as well. I think in Canada, some of the best examples have been in, I was typing there in Yellowknife, and the epidemiologists there, medical officer health, swear by it. What they raise is that, especially for the first attack. So you get a first attack, you test everyone and you find asymptomatic people, whether that's in a university residence or small municipality. And their concern is that what happens is you may have a traveler, like theirs is all travel. You may have a traveler that comes in, but they're in quarantine for 14 days, but you have transmission within the house. And so what they saw is that they were going to have these people that are out of quarantine and they were infectious, and they really feel that they interrupted transmission. I think it's still evolving, and am I convinced of that? I'm not quite sure. But remember, like in Ottawa, we've had times where we've entered into earlier restrictive measures because of the wastewater signal. And so even at a large 1 million person city, wastewater is changing policy that, from our best evidence, should be reducing transmission.
Thank you. There's another question for Ramsey. Ramsey, you mentioned that in a university setting, they tested the residents. Other than heightened surveillance in a setting early, based on early testing, are there any other recommendations of steps to take?
I mean, outside of testing, I think one of the challenges, vaccination rates as well, like when in terms of going back to school and things like that. But with regards to wastewater surveillance, it does come down to, the barriers as well in terms of being able to go for a test as well. So we were able to offer on-site testing directly at the residence. So we removed that barrier. We were able to work with our partners at the university to get ahead of that challenges. So as Doug was mentioning earlier, there is some delay for when an individual goes to go get tested from being symptomatic to then making that decision to actually go to an assessment center to get tested. We were able to remove that by a few days and mitigate those any potential outcomes of an outbreak. So we do see the benefits of why it's important and how we can shorten that gap from when we're seeing something in our wastewater surveillance to anything clinical that might develop to a person then going testing.
Thanks so much. There was a comment here from U of T that they had a positive signal at U of T too and provided testing at the residence. The compliance rate was over 85%, and maybe just alluding or suggesting the fact that that kind of information might help promote the testing that you're mentioning as well. The time is now 1:01, and unfortunately, there are a lot of questions, but we don't have the time to answer them all. Thank you to all of the speakers who were busy answering many of them during the presentation. This is great, but as it's time now to close up, I just really want to thank all of the speakers again, Doug, Bahar, Ramsey, and Shinthuja for their participation and the wealth of knowledge that they brought to this PHO round session. We all look forward to seeing you again, at various wastewater surveillance fora, and be well. Thank you all for coming on and making the time out of your busy schedules. All the best.